Sorry.
Okay, just roll it.
All right. So today's Curbside Consult is on trauma resuscitation. One of the quotes that really kind of tipped this off for me started from the National Association of EMS Physicians and the American College of Surgery Committee on Trauma. Their protocols, according to their guidelines, it says it's actually suggested to not resuscitate blunt trauma patients without a hospital cardiac arrest or penetrating trauma patients found pulseless, apneic, and with no signs of life, and to make death pronouncement at the injury scene. That was kind of a shocking statement to me. It was it came out of really nowhere because I see a lot of very aggressive therapy going on, at least here, and TV doesn't help the idea that a trauma victim is the utmost. We have to do everything for them. So let's start with just the basics of CPR. What role does CPR play in reviving a trauma victim or traumatic arrest? I'm sorry.
Well, first of all, I think that TV probably has a lot better success rate than we do. So the second thing is that we are particularly aggressive, I think, because of a couple of reasons. One, we're a training program, and so you guys need to see how to resuscitate a trauma patient, and not only that, the procedures that go into that, the ED thoracotomies, we're more aggressive about than probably is necessary. But we do it partially to make sure that everyone has some exposure to it. But the role of CPR, I think, can prolong the period at which you have your window to actually do something that is going to be meaningful. So a patient who is out in the field who has lost vitals in their 45 minutes away, that's somebody who you're probably not going to be able to do much about, because you're not going to be able to get them definitive treatment of the reason that they arrested in the first place, which is usually in most cases bleeding. So if you can't provide hemostasis, usually surgical hemostasis, then you're not going to be able to, CPR is not going to be effective. And so I think you have to look at CPR in trauma patients as kind of a modified CPR, modified ACLS. It's really to just maintain the vitals and a small amount of perfusion until you get them to a place where they can have a definitive thing occur. And that window is very debatable, how big that window is, and it depends on if they have an airway or not. It depends on whether or not they're dying from X injury versus Y injury. So it's really difficult to tell what that window is for all comers, and you have to divide into blunt and penetrating as well. So it's not an easy answer as to who or how much time out it's going to be the most benefit, but we tend to do it in everyone because the paramedics tend not to be able to determine like who's going to survive and who's not, and who is appropriate for and who's not. But the more time you're out, the more time you're down, obviously, the less likelihood that you're going to survive that.
So could we break it up into CPRs, the actual mechanism of CPR is more applicable in the pre-hospital arena and not intra-hospital arena?
Well, I think you do need to do some CPR in the intra-hospital arena, only because sometimes you don't have everything ready right away. And so if they lose vitals as they're coming off the ambulance, that's going to be your temporizing measure. And again, if we look at who we think are going to have the best outcome, it's usually the people who are 10, 15 minutes or less from losing their vitals. And if that 10 or 15 minutes happens inside the hospital, that also could be beneficial, because it may be that you don't have blood upstairs. It may be that you're not down to the injury in the lung yet. And so CPR can help you get to that point so that you can get everything ready and get things into people. So I think that it does have a role in the hospital, especially if you lose vitals right then and there. Not expected to, not prepared to, because you're not always prepared. Sometimes these patients just show up. And so, the fumbling around for a few minutes, you should be getting the airway and perhaps cutting into their chest at the same time if you have somebody who's a candidate for that. So it can bridge that short period of time until you get the things done that you need to get done.
Does it ever present more of a chaos to the resuscitation period? Have you ever felt that perhaps that just somebody getting up there and sort of getting in the way can actually be a detriment to the patient?
Only if they don't move when you're going at the knife, but I think, I suppose they're always chaotic, and the role of the person who's running the code is to lessen the chaos.
Nice.
I think that's an art. I think that when I see people have it, it's amazing, and the people in the room, I think there's a lot to be learned about how to run a code, how to do that teamwork, how to have your nurses and all of the people who are participating trying to focus on one thing and listening to the person. So I think that has a lot to do with it, how people run things, because I think that depending on who the attending is, the codes run very differently for a different person. So I'm not sure that is the thing that adds the chaos, as opposed to the way that the code is run.
Gotcha.
So,
do ACLS medications have any role in the resuscitation of a traumatic arrest?
Again, it probably just temporizes the problem, or the problem, which is the bleeding. I mean, you have some people who come in who are dying because of a head injury, and so in those situations, it's usually not a bleeding to death. It's more of a you've herniated your brain or the brain's on the street kind of death. So that's usually not something that is temporized by bleeding. Now, some people say, should we resuscitate those people at all? I mean, if there's an obvious head injury and those sorts of things, but I think that we just can't determine that. We don't know enough information when they hit the door to not. At the same time, if somebody codes 4 or 5 times from an obvious head injury, their likelihood of survival of that is pretty low.
End-tidal CO2 has made its way into the ACLS literature as really that hallmark of ROSC. Anything in the trauma literature, should we be using that more in our trauma patients?
You know, there's not a lot about end-tidal because, you mean in terms of determining when to stop, or?
When to stop, or when reperfusion has occurred.
Yeah, the challenge about reperfusion in trauma patients is it's usually extreme hypovolemia, as opposed to a cardiac arrest patient who's usually full. I mean, their tank is full. So I think that value may be not as accurate, and I don't know of much about that in trauma, that they've looked at that specifically. We have to use sometimes other markers of reperfusion because sometimes vitals are not adequate to do that. So if you had somebody who had, say, a splenic injury and was bleeding, and they had vitals that were okay, I mean, maybe a little tachycardic but blood pressure above 100, you may be able to see that patient and the vitals are okay, but they're really very underperfused. And the markers we use for that are base excess and lactic acid, and sometimes gastric tonometry, which looks at perfusion in the stomach, where you can put something in there and look at whether or not there's perfusion. So there are other endpoints in trauma that we use because usually it's hypovolemic, and the end organ hypoperfusion is something that's difficult to determine without some other parameters.
And you know, a '97 study showed that you cool a trauma patient and you kill them. With the
they usually come in pretty cold too.
It's true,
so,
but has anything looked at that again of post arrest resuscitation? You've gotten a pulse back, and now cooling them, sort of like in the ACLS algorithm. Has that been re-explored, or are we still at cooling is bad?
Actually, there is some amazing and extremely interesting work that's being done with that. The problem with trauma patients and cooling them is they usually come in cold. Even in Memphis, Tennessee, they come in cold, and it's because they have loss of the ability to warm themselves. They've uncoupled that. So we always run into coagulopathy, acidosis, and hypothermia.
Remember that's the lethal triad, interns.
The lethal triad. And so cooling beyond that, you would think, would perpetuate that. And usually it's an ongoing battle that we have even in the operating room. When they go upstairs and we cut open their abdomen or their chest, they're exposed in the operating room and they lose tons of heat, as well as, you know, we give blood products which come at 4 degrees from the refrigerator. So there's a lot of obstacles to keeping those patients warm. So a lot of times they are cold. And it's a bad thing. But that kind of mechanism of being cold is a different mechanism than somebody who's actively cooled. And some really, really amazing work is being done out of, it's a collaborative work, I think it's out of Harvard, it's either Harvard or Johns Hopkins, I know, I shouldn't really mix those two up, but they would all be very upset. But they're out of UPMC, Sam Tischerman and Peter Ree out of Arizona, and they're doing a collaborative look at what they call suspended animation, which is where you cool them to like 18 degrees. And you see whether or not in cardiac arrest that is not, and you essentially stop their heart. And so they're looking at extreme ends of cooling to see whether or not those patients are going to benefit from that. And they've done it in some animal models, and it's incredible. Wow. It's incredible. So I'm really excited about seeing where that goes, because I think that it's the complete opposite of what you think would be a benefit, but it's actually cooling them to the other extreme. Mm-hmm. So I'm really excited about seeing what comes out of those studies. I think they're starting up the first human trials. They're in the process of actually going through all their IRBs and the protocols and things like that right now, or at least as of last year they were. So it's really interesting, but you're right. Cooling in brain injury doesn't work. Cooling in patients who are traumatic or post-traumatic arrest, relative contraindication, because usually they're bleeding as well.
Sharp Memorial in San Diego has been doing a lot of work with ECMO. Is there any new thoughts on ECMO's role in the traumatic arrest patient?
Well, ECMO, the problem with ECMO is you have to be set up to do it. It's amazing if you're in Michigan how much more ECMO you'll see than if you're here in Illinois or even in the UK. ECMO has been looked at generally in critical care. I think that it's really going to be dependent on what your institution's able to offer, and sometimes it's very challenging to prove that it actually is helpful. Okay. So you have to have it right there, and again, you have to be on heparin. So it may not have a role, but I haven't seen much about ECMO in trauma patients recently.
What would be Dr. Romey's minimum efforts? Trauma arrest comes in, plenty of literature is out there saying we've got a 10 to 15 to 30 to 45-minute window. There's no point in resuscitating. What at least should every patient have done to them prior to calling the code?
Well, I think that it depends on the type of trauma. So the paramedics can call people dead out in the field if they're decapitated or they're cut in half or, those sorts of things. So obviously we're not going to be seeing those sorts of things. But blunt trauma that comes in, and they're more than 15 minutes out with 3 zeros, I think because of where we work, because we work at Christ Hospital and everyone needs to have some opportunities to do things, I'd usually put a chest tube in both sides, an airway, and maybe a line. We do maybe some CPR, probably put an ultrasound on to make sure they don't have tamponade, or at least something on their abdomen to see if we can do that. If you can restore some meaningful perfusion from that, then you may have some effort to do it within that amount of time. Even if they came in greater than that, I still may do that, only just because there are some people who haven't put chest tubes in yet, to be quite honest with you. And so I think that, with the resources that we have and the resident complement that we have, that we're able to do those things, not because they're right to do in every situation, but because I think that it's a meaningful exercise for us to go through for resident teaching, but also, we often feel that these patients come in and to do absolutely nothing is a really hard thing mentally to get over. But I think that, it's worthwhile for us to at least get the teaching opportunity out of that. Even though that sounds awfully cold, but at the same time. So that's for blunt trauma. For penetrating trauma, if they have a penetrating trauma that is in an extremity of some sort, and they've died from that, then there's little you can do from opening a chest to do something about that. I had a guy who came in who arrested from a femoral vein injury, arrested. And so all we did was had the medical student hold pressure, and we got the blood up as fast as we could, and we shoved it in him while we were doing CPR. A little bit of epi here and there. And he actually came back and had a neurologic recovery completely. So it's really just making sure that in the traumatic injury patient that you have a definitive repair and you restore the losses that they've had, which is almost always volume and blood. So it's difficult.